Hi, I am Dr. Yeshwant Mane, Director, Atharva Infertility Center, Nashik. Today we will be discussing the most common finding or the most common presentation we see in infertile females, that is polycystic ovarian disease. Now, what is PCOS? PCOS is defined as polycystic ovarian syndrome or polycystic ovarian disease. Now, how would you diagnose PCOS? According to Reproductive consensus, either two of the following three has to be present in a female to diagnose her as having polycystic ovaries or polycystic ovarian disease. Irregular periods. The periods have to be irregular at least 45 to 60 days of interval, or sometimes the periods could be delayed, or in few females the periods could be only after withdrawal tablets. Second, features of hyperandrogenism, that is acanthosis nigricans, excessive hair over the face, arms, chest and all over the body, and ultrasound diagnosis, ultrasound appearance of polycystic ovaries. In ultrasound, we see a typical polycystic arrangement of the follicles, the small follicles which are arranged in the periphery of the ovarian cortex. It is just like a simple necklace-like appearance where 2 to 6 millimeter follicles are arranged inside the ovarian cortex. Plus, the ovaries are enlarged in size. In normal cases, the normal ovarian volume is 10 cm cube. But in cases of polycystic ovaries, the ovarian volume is increased. And the ovarian volume, when it increases, it has a stroma, and that stroma secretes a hormone called as androgens. Now, what are androgens? Basically, androgens are male hormones which are present in the ovary. Under normal circumstances, a female should have two hormones in appropriate proportions. One is the female hormone, that is estrogen, and another is the male hormone, that is androgen. When the female hormone levels are high and the male hormone levels are low, that is androgens, the female has typical feminine features, soft voice, soft skin and regular periods. But when the endocrine environment changes from estrogen predominant to androgen predominant state, ovarian stroma secretes large quantity of androgens, and this androgen is responsible for excessive hair growth, acne, acanthosis nigricans, harsh voice and irregular periods. So, if the female is having either two of the above three symptoms or features, the female is labeled to have as polycystic ovarian disease. Now, what are the causes for polycystic ovarian disease? The polycystic ovarian syndrome. The main important cause for polycystic ovaries is genetic. Suppose the mother was having some symptoms or signs of polycystic ovaries, there is a very likelihood of the daughter having the same symptoms. Second, it is hyperinsulinemia. Hyperinsulinemia, because of the increased levels of insulin levels, the symptoms of polycystic ovarian disease gets exacerbated. Third, and the most important thing which we find in our day-to-day practice is obesity. Any normal male or a female, they have to have their weight in the proportion of the height. So we calculate that in the ratio of body mass index or BMI. A normal BMI is between 19.5 to 24. If the BMI is between 25 to 30, the female is classified as being overweight. If she is between 30 and 35, she is classified as being obese. And if the BMI is more than 35, she is called as morbidly obese. So the main culprit is weight gain. Many times we come across patients complaining that because of the weight gain they are not able to menstruate properly. But the increase in weight is the main culprit for her irregular periods and hypomenorrhea or decreased amount of blood flow which they are present at the clinic. Now, what is the treatment for polycystic ovarian disease? The treatment for polycystic ovaries is, the most important is lifestyle modifications. Second, dietary modifications. They need to decrease the amount of junk food, the carbohydrates, and increase the amount of proteins. And daily exercise. Daily exercise is a very important part of day-to-day activities. In some cases, we can give insulin sensitizers like metformin to decrease the levels of insulin. Now, if the female presents at the clinic in the adolescent age group and in the reproductive age group, the treatment option varies. If she presents at the adolescent age group, the main treatment includes weight loss. Weight loss is the most important part of the treatment. Suppose you find a female who presents at the clinic with BMI in the category of overweight. Suppose she is having 75 kgs of weight. and you tell the patient that you need to come down to 60 kgs. It is not practically possible in majority of the females. What you need to advise the patient is, if she decreases 2 to 5% of her actual body weight and decrease her weight by that ratio, her periods will be regular. She will get her regular periods and she will start ovulating regularly. And later on, the response to the exogenous stimulation, like stimulus, if you want to induce ovulation, increases very significantly. If the female is in the adolescent age group, first is the weight loss, dietary changes. She needs to decrease the amount of carbohydrates. She needs to do a lot of outdoor activities, decrease the use of mobile phones, TV and other electronic gadgets. And if she can spend more time outdoors, that will help in decreasing her weight. And in some cases, we can definitely give in the adolescent age group metformin, that is insulin sensitizer, which are helpful in decreasing the levels of insulin, and oral contraceptive pills, especially the anti-androgen oral contraceptive pills, at least for a period of 6 to 9 months. So these oral contraceptive pills will correct the hormonal imbalance which has occurred in cases of polycystic ovaries. They will decrease the amount of estrogen and increase the level of androgen. If the girl is in the adolescent age group and she has features of acne and hirsutism, we need to understand the hair cycle. The hair cycle, it has a typical growth phase, the resting phase and a falling phase, that is called as anagen, catagen and telogen. So any female to have significant impact on the growth of hair present all over the body, she needs to take treatment for at least 9 to 12 months, because treatment lesser than 9 months is not going to disturb or not going to break the hair cycle. So in order to break the hair cycle growth, the oral contraceptive pills need to be given at least for 9 to 12 months. Now this is the adolescent age group. Now we'll go to the reproductive age. In reproductive age group, if the female is wanting to have a child and she presents with features of polycystic ovaries and infertility to the clinic, the most important thing is weight loss. Weight loss is the most important advice a doctor gives to the females in polycystic ovaries. Lifestyle modifications, dietary changes and insulin sensitizers. When she gets the withdrawal bleed, ovulation induction can be induced with some tablets, either clomiphene citrate or letrozole. The initial aim of ovulation induction, it has to be a monofollicular growth, because polycystic ovarian disease or patients with polycystic ovaries, they tend to hyperstimulate, and the dreaded complication of ovarian stimulation or hyperstimulation is ovarian hyperstimulation syndrome. So you need to be very cautious, very careful when dealing with ovulation induction in patients with polycystic ovaries. If the female responds to ovulation induction, that the follicle is growing at regular intervals, reaches up to 18 mm and ruptures after giving a trigger, then she has a very good chances of getting pregnant. Now, when you give clomiphene citrate or letrozole, you tend to come across two types of responses. One is clomiphene resistance and one is clomiphene failure. When you tend to, what is clomiphene resistance? You start with a dose of 50 to 100 mg and you do an ultrasound scan on day 10 or day 12 of the menstrual cycle, and you see the follicles are not growing or the ovaries is not responding to the exogenous stimulation. Now what do? You tend to increase the dose. Even after increasing the dose, the ovaries fail to respond to produce a healthy or a dominant follicle. These cases are called as clomiphene resistance. The other category is called as clomiphene failure. What is clomiphene failure? A female responds to the exogenous stimulation with ovulation induction drugs. The follicle develops and it ovulates, but she fails to conceive. That is called as clomiphene failure. So there is a difference between clomiphene resistance and clomiphene failure. If the patient comes into the category of clomiphene failure, you can try for at least 3 to 6 months depending upon the age of the female. Age is the most important criteria to decide the further line of treatment. If she is less than 30 years, with a normal BMI, with a normal husband semen parameter and patent fallopian tubes, you can definitely try few cycles of IUI. So IUI will definitely help. Like in IUI, you tend to superovulate the ovary. You tend to develop around about 2 to 3 follicles in the ovaries. This is achieved by exogenous tablets like clomiphene or letrozole, plus you add exogenous gonadotropin. these gonadotrophins which are administered, they stimulate the growth of additional few follicles. So you can imagine a cycle in which one follicle develops and rupture, that is with ovulation induction tablet, or a cycle in which you stimulate the ovaries with ovulation induction plus gonadotrophin and develop 2 to 3 follicles, and you do IUI in that particular cycle which has produced 2 or 3 extra follicles, and if you do IUI, chances of getting pregnancy increases. But this procedure or this treatment has some drawbacks. The most important drawback is the cost. Adding gonadotrophin to the treatment increases the cost of the cycle. And other disadvantage is when multiple eggs rupture, there is a possibility of multiple pregnancy. In fact, the most common cause for multiple pregnancy is not IVF. The most common cause for multiple pregnancy is ovulation induction with either clomiphene or letrozole or gonadotropin. If the patient responds with ovulation induction or with IUI, that's fine. If some group of patients, they don't respond to ovulation induction or with IUI. So in this group of patients, the next line of treatment would be IVF. IVF in patients with polycystic ovaries is done by a all-freeze protocol. Now, what do you mean by all-freeze protocol? All-freeze IVF cycle, you tend to divide the treatment in 2 parts. The first part includes stimulating the ovaries with gonadotrophins, producing eggs. The normal intention in an IVF cycle is to produce 8 to 10 eggs. But the disadvantage with polycystic ovarian disease is these females tend to hyper-respond, or the ovaries get hyper-stimulated. So if you intend to develop 10 to 12 follicles, it is not very surprising that you may find the female produces more than 15 to 20 eggs. This is called as ovarian hyperstimulation. So in the first part in polycystic ovarian disease, in an all-freeze protocol, you give injections till the follicle reaches 18 millimeter of size, and you give the trigger. The most important cause for ovarian hyperstimulation is HCG injection. The moment you give HCG injection, it initiates a cascade of events into the body, and that leads to hyperstimulation. So in all-freeze cycle, instead of giving a HCG injection for ovarian trigger, you give GnRH analog in the form of decapeptyl injections. When you give injection decapeptyl, then you do the ovum pickup after 34 to 35 hours. The greatest advantage with this all-freeze protocol is that the incidence of hyperstimulation has completely been obliterated. So at Atharva Infertility Center, since last 10-12 years, we have been very religiously practicing the all-freeze protocol, and we haven't seen any ovarian hyperstimulation since last 12 years. So after doing the ovum pickup, the husband's semen sample is collected, the embryo is produced, it is grown to a particular day, either day 3 or day 5, and the embryos are frozen. So we don't do embryo transfer in the pickup cycle, or that is called as index cycle. After a month, when she gets a period, we assess around day 2 or day 3, depending upon the size of the ovary. If the ovarian size has shrunken, if the follicles have disappeared or the corpus luteum have disappeared, we prepare the endometrium. Or we wait for a month to completely bring the ovarian size to normal. And in the subsequent month, we prepare the endometrium with exogenous tablets, hormonal tablets. And when the endometrium becomes receptive, that is, it appears morphologically triple line, and it is anything between 7.5 to 12.5 millimeter and has got a good blood flow, we remove the frozen embryos, and these frozen embryos are transferred back into the uterus. So this is a very safe, very effective and widely practiced protocol for patients undergoing IVF with polycystic ovarian disease.